Hello, everyone, and welcome to our Life Unites Us webinar, Understanding Medetomidine in Today's Evolving Landscape. So excited to be with you all today to discuss this very important topic. So I will jump right in with a quick overview of our agenda. So starting with some welcome and housekeeping, then jumping into our campaign overview, just a quick little tidbit about Life Unites Us, and then our speaker introduction, handing over the reins to Shannon, who's joining us today, and then wrapping up with a Q&A. So in terms of general housekeeping, please feel free to introduce yourself in the chat. We love to know who's in the room with us, your name, the organization that you're calling in from. This webinar will be recorded, and a copy of the presentation will be available on the Life Unites Us website. Certificates of attendance are available upon request as well. So all attendees will be muted throughout the presentation. But like I mentioned, please feel free to use the Q&A button at the top of your screen to ask any questions. We'll revisit all those questions during the Q&A. And then the chat is also available for your use throughout the webinar. To adjust your view and see all of the speakers, you can click View at the top of your screen and then select Speaker or Gallery. And then to access closed captioning, you can click More, select Language and Speech, and choose Turn on Live Captions. And now a quick overview of the campaign. So for those of you that might not be familiar with Life Unites Us, we are an evidence-based public health intervention designed to reduce addiction-related stigma of substance use disorder in the state of Pennsylvania. The campaign is a collaborative effort between Shatterproof, Penn State, and the Public Good Project in close partnership and funded through the Department of Drug and Alcohol programs. We have three primary objectives. We're working to increase knowledge about substance use disorder and that recovery is not only possible, but probable. We're working to improve attitudes towards individuals with SUD, and we're also working to strengthen the capacity of stakeholders and organizations who are already responding on the ground. In terms of our pillars of work, we have three primary pillars. The first is community engagement. We connect with community-based organizations across the state to help share Life Unites Us messages and amplify stories of those affected by SUD. Our CIC, which is our Community Impact Committee, is a continuum of that work. We share real stories, so we collect and share stories of recovery and allyship across Life Unites Us social media channels. We're also changing attitudes by promoting messages that speak to hope and recovery. And lastly, we provide resources and tools. So we facilitate educational webinars like the one that we're on today, distribute monthly newsletters, and create downloadable content that can be used to educate your communities. So please feel free to check us out. We are on Instagram, Twitter, and now TikTok at Life Unites Us PA, and on Facebook, we're at Life Unites Us. And if you're interested in sharing your story or becoming a partner, we'll be dropping the links in the chat right now, or you can feel free to also scan this QR code. So now we'll go ahead and introduce our speaker. We're joined by Shannon Ashe today. She is one of the co-founders of the Everywhere Project and a licensed social worker presently working in an outpatient substance use setting. Shannon has worked in the behavioral health field for more than a decade and is passionate about harm reduction and supporting people who use drugs. And with that, Shannon, I will stop sharing my screen and pass it over to you.
Hi, everyone. Thank you for joining us today. I am going to start sharing my screen.
Yes.
Okay. So we're going to talk about Medetomidine today. It is the newest alpha-2 agonist to appear in Philadelphia's illicit opiate supply. As you can see right by the heading, it has also created significant issues with withdrawal and put a lot of pressure on the medical system. So an important note on the ever-changing drug supply. research is still emerging. It's new. It's not necessarily new to the supply, but it's new in terms of gaining awareness. The impact is growing, and so we don't really have all the answers at all. This presentation is meant to educate, inform, and be a basis for harm reduction for people who use drugs by preparing the people who support them for this issue and how it may present. We develop this information directly from working with folks on the street and also from the sources that will be cited. It's important to note, though, that different combinations of substances within different regions may have different impacts. Our agenda. So we're going to start talking about what it is, the timeline, adverse effects, xylazine, which is another alpha-2 agonist, discuss overdoses, withdrawal, treatment, and then just a list of sources and how you can contact me. So what is medetomidine? Medetomidine is a tranquilizer and an alpha-2 agonist similar to xylazine. However,
Shannon, just a quick note, it looks like the slides are a little blurry, and your video is as well. I'm not sure if maybe it's the internet connection. It might be helpful to turn off video, and then that might help with the connection a little bit.
Is that better?
That looks a little better. It's still slightly blurry, but we will be sending these slides afterwards as well. So let's just move forward and then we can go from there.
So what is it? It is an alpha-2 agonist similar to xylazine. It was first found in the Philly drug supply at the end of April 2024, and then was found in 76% of samples tested in PA in the first 6 months of 2025. So it does have clinical purposes in humans. It induces sedation, so it's used in anesthesia. It's an I always say this word wrong. Analgesic causes an inability to feel pain, and anxiolytic causes a level of sedation associated with extreme relaxation. So this is an important piece. People may panic when they come across somebody who is not responding, even though that person is breathing. And so we really want to make sure that we stay calm and assess for the presence of breathing. Withdrawal is high risk and hospitalization is required, and we'll talk more about that later. So when did medetomidine become an issue? One thing I do want to note real quick, though, is that it's similar to xylazine, but is a lot more potent. Estimates up to 200 times more potent than xylazine, and it has a longer duration of action, which means that it lasts longer. And those are other factors that make this challenging to deal with. So, like I said, it was first discovered in Philadelphia in April of 2024. And in the last 4 months of 2024, it became the primary dosor, overtaking xylazine. Since then, it's begun to show up in the other places in the US and Canada. This article right here is from this week. It was just 2 days ago, I think. It says, oh no, I'm sorry, that's a different one. This one is from December, when it was found in Cincinnati. So what prompted this change is kind of a controversy. Some people think that it was a direct response to the xylazine scheduling, which was temporarily scheduled in 2023 and then permanently scheduled in May of 2024. But, there's no way to really conclusively know. So there's just some people think that, some people don't, and yeah, keep it moving. So symptoms: deep rate of unconsciousness, respiratory depression, cardiac and circulatory depression. So we're talking about low heart rate, dry mouth, dilated pupils, hypothermia, low body temperature. So that's not something that we typically see, and is an additional thing to be managed and aware of. So other symptoms are muscle spasms, low heart rate, high blood pressure, and peripheral vasoconstriction. So the skin appears blue and can mask actual cyanosis, which is a lack of oxygen in the body, if the person's not under medical care. So it's important to distinguish the differences, the similarities as well. Like I said, they're both alpha-2 agonists. Both substances cause significant sedation. So the presentation may initially be the same. Both presentations cause vasoconstriction and will slow healing of wounds. Both cause respiratory depression, and neither are approved for human use. So they are both veterinary sedatives, though medetomidine does have a version used in humans. So the difference is that medetomidine is considered to be stronger, has a longer duration of action, and unlike medetomidine, there is a version, unlike xylazine, there is a version that is approved for use in humans known as dextromedetomidine with a brand name of Precedex. So these are good symptoms to be aware of, because it can be a good indication that the supply contains these things. We don't see muscle twitches, we don't see hallucinations with typical xylazine use. We also don't really see the increase in urination either. So these are asterisks because they can be good indicators. So medetomidine does affect overdoses. And this is the article that I was thinking about a few minutes ago. It talks about, it was the 26th, so just a couple of days ago. In British Columbia, Canada, they had a single-day record for paramedic calls due to the impact of medetomidine being added to the supply. Overdoses involving medetomidine are challenging because the individual may remain unresponsive even if they're breathing independently. While we did see this with xylazine, the biggest difference here is the potency and the duration. So xylazine has a tendency to wear off in a relatively short period, whereas medetomidine lasts much longer. And so the individual may remain unresponsive even though they are breathing and don't need naloxone. So responding to an overdose involving medetomidine. So it is a alpha-2 agonist and not an opioid. So that means that it's not going to have, the naloxone will not have an effect on the medetomidine itself. However, it's found in conjunction with fentanyl. There was a recent overdose event where there was significantly more medetomidine found in the samples tested than there was fentanyl. But that doesn't mean still that we wouldn't use naloxone if someone isn't breathing. And again, by not breathing, I'm talking regular, normal breath. If someone is labored, gasping, snoring, shallow breaths, the use of naloxone is recommended, regardless of what else may be in the supply. We also want to prioritize rescue breathing because respiratory depression, people need oxygen to be able to survive. You can utilize the rescue position, which is described right here. The top hand supporting the person's head, the bottom arms to the side to stabilize, and the top leg forward to prevent rolling. I also like to place something behind the person's back. If I have a backpack or they have a backpack, I find that to be helpful in stabilizing as well.
Shannon, just sorry to interrupt. I think I have those slides pulled up now on my end. Maybe if you could stop sharing your screen and I'll share mine to see if that improves the video quality.
So the primary concern regarding medetomidine, in addition to the sedation right now, is the withdrawal. Historically, opiate withdrawal has been extremely uncomfortable, but aside from risk of dehydration, has not carried the risk of being fatal. However, that's no longer the case. We are having reports of seizures and other issues that require ICU admission, and people need to seek medical treatment. A few weeks ago, the New York Times came out and did an article about how the withdrawal is putting pressure on the medical community and having a profound impact on how people are getting care. And with medetomidine withdrawal, the main goal will be to stabilize, making sure that heart rate, blood pressure, and organ functions are all within normal limits. Because like we discussed, changes in heart rate and blood pressure are a significant concern. Medications that work for medetomidine withdrawal, which are dexmedetomidine, also known as Precedex, are only available in an ICU setting. So folks do need a high level of care to be supported with this. Symptoms of withdrawal, again, high blood pressure, rapid heart rate, high anxiety. And that's probably one of the ones that folks are going to notice first, is just really high, unmanageable anxiety, along with that agitation and sweating. Now, if people are experiencing confusion, vomiting, headache, or loss of consciousness, that is a medical emergency and they need to seek care immediately. Like we said, people can have seizures. The low heart rate is a concern, as well as the low blood pressure. So before we get into like what the treatment is doing, it's just so important to emphasize that people need to get emergency help. We understand the barriers to care and that a lot of people are not comfortable doing that, but it literally can be fatal if people do not seek emergency care and get the level of treatment that they need. We have encouraged people outside of Philly to go to larger institutions that may be associated with universities. They might be more likely to have an idea of what they're up against. But just like with xylazine, as it was emerging, people are going to have to learn as they go, and hopefully, we'll seek out the expertise of the research that's coming out of Philly on how to best address this. So treatment. The first thing that was tried is to utilize the same things that were treating xylazine withdrawal. These were ineffective, and this was reflected in some research from Philly this year, or last year now. And in a different study last year, 83% of individuals admitted for medetomidine withdrawal were treated using dexmedetomidine, which is the human prescription version of the substance. There was a larger scale study conducted across 3 hospital systems, correlated with the time that medetomidine rates increased. And 91% of patients who presented for alpha-2 agonist withdrawal were admitted to the ICU, and 24% required intubation. So they were not able to breathe on their own during the period of withdrawal. And again, this just underscores how important it is for folks to get emergency care as soon as possible when they start to experience withdrawal symptoms. The risk is significant, and it's not something that you can kind of wait and see. Okay, so we definitely moved through the slides a little bit faster than I was expecting to. Ashley, is it okay if I answer some of the questions in the chat?
Yes, absolutely. So we can dive right into our Q&A. Thank you everyone so much for your patience with the slides. As we mentioned, they will be available for download. So all of you will have those available. I am seeing some things in the chat. John just asked, are there particular institutions familiar with medetomidine overdose withdrawal protocols?
I would say the ones in Philadelphia, Jefferson, Temple, Penn, they're all going to be familiar with how to handle withdrawal symptoms. Outside of Philadelphia, I can't speak to it.
I'm seeing a question in the chat. How quickly will it be available for affordable testing?
So there are testing strips available, but they're not really affordable. How quickly that happens, I can't really speak to.
Right. A question from Ashley. Is there a street name for medetomidine?
Some people have called it Dex, Meditrank, just Trank. It's not, it's a long word to say, right? So I don't think people are walking around using all four syllables, but nothing specific and consistent that I can share.
And just to follow up on the testing question, you mentioned test strips were not necessarily affordable. Would you say that they're reliable as of right now?
I've not personally used them, but in general, the BTNX testing strips are reliable.
I'm seeing a lot of engagement in the chat. Thank you so much, all. Let's see. Will it show in urine drug screens?
Only if it's tested for. So, like any substances, if you run like a regular drug panel, no, you're not going to find it. It would have to be specifically tested for within the UDS.
Thank you. I know with xylazine, it can create open wounds at the injection sites. Is this also seen with medetomidine?
No, so we're not seeing new wounds as a result of medetomidine, but it does report slower healing. It still is a vasoconstrictor, and so it impacts the flow of fresh blood to the area.
Just a question on some of the Philadelphia hospitals that have started to encounter these cases. Have they indicated need for ICU placements and medically induced comas?
Yeah, so a study across 3 hospital systems found that 91% of people did require ICU admission. And among those, 24% of people required intubation. So they were sedated in order to be intubated.
And I'm seeing some questions around maybe doing some presentation to other groups of providers. For those, I would just encourage you to send an email to me. I will drop my email in the chat, and I can forward all of those to Shannon. Or Shannon, if you want to drop your email in the chat for folks to message directly, that's also something that we can do. I'm seeing a lot on, for organizations focused on public education, what's the most important distinction people need to understand about medetomidine compared to opioids, particularly around overdose response and the role and limits of naloxone?
Yeah, I think that's a great question. I would say the biggest thing in terms of overdose presentation is that people are not going to respond the same when naloxone is administered. Historically, people would respond by waking up and be able to engage with them, but we're not seeing that same impact because medetomidine is not an opiate, so naloxone does not act on to remove it. People may resume breathing, or that doesn't necessarily mean they're going to wake up and start having a conversation with you. There was another part of that question.
I think you covered most of it just in terms of what sort of messaging for orgs that are interested in putting out educational messaging around this. What are some of those important distinctions, which you covered, but anything else related to overdose response or naloxone?
Yeah, I would just emphasize the fact that you still want to use naloxone in the absence of breathing or in the presence of labored breathing, um, gasping, snoring. Just if you're not sure if someone is able to breathe, really try to assess that and utilize naloxone if necessary.
Thank you so much. Trying to catch up here on this chat. So much good content. Thank you to everyone who is sharing resources.
So I see something about once in treatment, the AMA rate higher. I know that the AMA rate was significantly higher for xylazine, which is, like we said, similar. I'm not sure if there's any research currently looking specifically at medetomidine, but that was a huge issue with the xylazine withdrawal, and a lot of that has to do with the anxiety and agitation that people experience.
Shannon, I know I'm seeing a lot of resources being dropped in the chat. Do you have, any recommendations that currently exist to help individuals stay informed about medetomidine?
Yeah, so we also have some educational stuff on our website available. PA Groundhogs is our source and partner in drug testing in Philly. We talked about them a little bit earlier. And yeah, I think that we'll start to see more academic and publishing about this, like we did with xylazine when it blew up and became problematic. Unfortunately, probably going to follow a similar pattern.
Thank you. I'm seeing one more question in the chat. Are you seeing reports of individuals stating that they are not using opiates, only use of meth, crack cocaine, but have the effects of medetomidine?
Not that I'm aware of.
Just quickly looking, if a client is denied at the hospital for met use, what other resources should we give them to help with their withdrawal?
I would take them to a different hospital. Like we talked about before, the risk of seizure, the need for so many folks to go into ICU and need breathing support. That's not a risk that I would suggest taking.
A question from Christine. Once an individual is stabilized from withdrawal, is there any research regarding behavioral presentation, cognitive functioning changes due to the use of MET or xylazine?
I don't believe so. Anything that we would know would be anecdotal and likely not enough time to truly get through symptoms of post-acute withdrawal to see what long-term impacts might be. That's a great question. Thanks, Jen, who said in Europe there's been a few reports of meth made with medetomidine, but not in the US. Jen is my partner in the Everywhere Project. So
Thanks, Jen.
thanks for contributing.
Someone else asked something around dangers of cross-contamination, like there was with fentanyl.
I mean, there's always risk of cross-contamination. There's not, people aren't creating these drugs in labs, using sterile equipment. So yeah, I would say that there's always a risk of cross-contamination.
Yeah, we have another question from Audrey. Are there any synthetics similar to Met that might be coming?
Like synthetic sedatives. Yeah, I mean, there's research chemicals coming out constantly all the time. That's not necessarily my area directly. I guess the answer is always yes. It could definitely show up.
Thanks, Shannon. And this is the last question that we will take.
Can I answer the one about from
Please,
Karen?
go for it. Go for it.
Okay, Karen. Xylazine is not addictive. So xylazine is not addictive in the way that like you might think, but people build dependency. So without dependency, people won't experience withdrawal, especially physical withdrawal. So the way that we typically define dependency and addiction is a little bit different when we're talking about physical withdrawal and physical dependency. So it's not necessarily that it's addictive, but when someone's using it for so many days in a row because it's already in their supply, then their body adjusts to it and they become dependent on it to regulate their internal systems. I hope that answered your question. And the last one, they are being seen together, and it also is replacing it. It has replaced it as the primary adulterant seen in the affiliate drug supply, but xylazine has not completely disappeared either.
Thank you so much, Shannon. And thank you to everyone with all the wonderful questions and engagement. Like we mentioned, a recording will be shared. Taylor also dropped a link to our post-webinar survey, so we encourage you to fill that out and provide some feedback for us. Thank you all so much for your time. All right, thanks everyone. Have a good rest of your day.